Hi everyone, my name is Brianna, and this week Pam and I will be starting off week 1 of Neuro and Psych Drugs.
We wanted to start off by talking about Alzheimer's disease.
So Alzheimer's disease, or AD, can be characterized as disruptive memory loss, difficulty in completing familiar tasks, confusion regarding place and time, poor judgment in decision making, withdrawal from interests or hobbies, and changes in mood or behavior. Characteristics of AD are presented here, mild, moderate, or severe, as categorized by the MMSE, which is the mini mental state examination that again qualifies the severity of the Alzheimer's disease for patients. So the higher the score, the less severe the Alzheimer's disease is. For our treatment strategies, patients with Alzheimer's disease have different treatments that can be recommended depending on if they have mild, moderate, or severe disease. You can see kind of the stepwise approach that's presented here. So we start out with acetylcholinesterase inhibitors, moving then to adding on an NMDA antagonist, and then when severe, kind of the same as moderate. There's not a lot of add-on potential once you've reached the moderate stage. Goals of treatment are to preserve cognitive function and ability, minimize behavioral disturbances, and slow the progression of disease and effects brought on by the destruction of neurons. These are not curative treatments. That's important to know and make patients and their caregivers aware that these do not cure Alzheimer's disease. They simply slow the progression. So pharmacologic therapies include acetylcholinesterase inhibitors, including donepezil, rivastigmine, and galantamine. Probably the most common one is donepezil. Not a lot of big side effects, but something to look out for. GI upset and nausea can be pretty impactful on our older patients, so just something that you want to make sure that they're aware can happen. And then our NMDA antagonist, memantine or Namenda, you may see prescribed as well. And something to look out for with that one is dizziness, so making sure patients are aware that can occur and encouraging them to rise slowly from sitting or laying down so that they don't have a fall. This is some more specific information about these few drugs that I just presented. So kind of on the left-hand side, the acetylcholinesterase inhibitors, and then on the far right, memantine or Namenda, and kind of their place in therapy is mild, moderate, severe treatment, and kind of how to titrate them as well. Something interesting about rivastigmine, it does come in a patch formulation, so that's another option for patients who can't take anything by mouth or have trouble taking pills or tablets. So just something to be aware of as you kind of treat these patients.
We do have 2 newly approved monoclonal antibodies that reduce amyloid beta plaques, and these include aducanumab, an IV infusion given every 4 weeks, and lecanemab, an IV infusion given every 2 weeks. Adverse effects include infusion-related reactions, headache, amyloid-related imaging abnormalities such as edema and hemosiderosis. These are very controversial agents because although they have been approved by the FDA, there's not a lot of data to prove that there's actually clinical benefit to either of these, and so these would not be either go-tos as first-line agents. We also can use antioxidants such as vitamin E. This has limited data to actually show efficacy in mild to moderate disease, but it is considered to be safe and tolerable in most patients, so it is an option for those patients who have mild to moderate disease.
As far as assessing efficacy in these patients, again, these treatments have not been shown to decrease mortality or cure Alzheimer's disease by any stretch of the imagination, but they may slow down the progression of the disease. So that's important, again, to make sure that caregivers and patients are understanding that this is not a cure, but more of a slowing of the Alzheimer's disease. As you assess these patients, it's important to know that the history provided by the family member or caregiver at home may be more accurate than an in-office assessment, because these patients may be able to perform better when they're in a more formal setting with their provider as opposed to kind of living their day-to-day life with their caregiver or family member at home. As far as titrating medications or switching therapies, medications are deemed ineffective when you use them for at least 6 months and you had deterioration of functional autonomy, global impression, and scale or behavior. So again, within 6 months of treatment, if there's no improvement or if there's deterioration, that would be ineffective despite inadequate trial. Another thing to make sure patients and caregivers are aware of is that anticholinergic medications, both over-the-counter and prescribed, may interfere with the efficacy of Alzheimer's medications. So if you see these medications on the patient's profile, or even as you start these medications, it's important to make sure that they know that starting new meds may interfere with the efficacy and the slowing of the progression of the disease with these meds. To summarize for Alzheimer's, treatment options include acetylcholinesterase inhibitors and/or NMDA antagonist. Treatment goals include delay of progression of the disease since treatment is not curative. Family members and patients should be educated on the treatment goals and expectation of the medications, and medication should be used for a minimum of 6 months to ensure an adequate trial before deeming them ineffective. Moving on to our next disease state, Parkinson's disease. Parkinson's disease can present with bradykinesia, a resting tremor that actually occurs in 2/3 of patients at diagnosis. It can be pill rolling in the hands. Unilateral is usually the initial presentation, and then can move to kind of a bilateral presentation over time as the disease progresses. Muscle rigidity may also be common with a cogwheel or ratchet-like quality, and then gait dysfunction, postural instability may also occur with these patients. This is a slide that explains dopamine's role in Parkinson's disease. You may remember from pathophysiology kind of the role that dopamine plays. Essentially, Parkinson's is caused by a decrease in the level of dopamine in the brain, and since dopamine is a neurotransmitter that helps kind of coordinate smooth movements of the muscles, you can kind of see those symptoms that I previously discussed around Parkinson's develop when the levels in the brain drop lower than usual. So this slide also incorporates the mechanism of action or the site of action for common medications that we use to treat Parkinson's disease, which I'll go over kind of as we progress. For these patients, our goals are to manage symptoms to preserve the ability to perform their activities of daily living, improve their mobility, and minimize adverse events and treatment complications. The strategy for treating these patients is to initiate medications when symptoms start to interfere with those activities of daily living, and all patients will eventually require treatment with levodopa. This can be started at the onset of Parkinson's or later using the levodopa sparing strategy. Levodopa efficacy does wear off over time, so for patients who are kind of early in their disease state, we may reserve that treatment with levodopa until they're later on in their disease progress so that we can exploit the efficacy kind of when they most need it in their most severe state.
So here is a treatment algorithm for Parkinson's disease. Kind of details what medications can be considered based on symptoms and age. So when we start at the top, we kind of identify any presence of symptoms, if there's any areas of impairment that the patient is complaining about, and then with the first symptom being tremor, we kind of look at the age. So if the patient is less than 65, that's when we would consider an anticholinergic drug, versus if a patient is older than 65, that's when we go straight into carbidopa, levodopa. If the patient is having bradykinesia or more rigidity symptoms, they're again less than 65, so that younger patient population, we go for a dopamine agonist. And if they're older than 65, we go for carbidopa, levodopa. And then as we go down the algorithm, what's really kind of important to note is that for our older patients, really we're going to start trying to use the carbidopa, levodopa, and trying to avoid using the carbidopa, levodopa in our younger patients, kind of to get into that dopamine sparing strategy that we talked about earlier, so that way some of the other complications and adverse events that can happen with carbidopa, levodopa, which I'll talk about in a moment in further slides, so we can try and avoid those and get the most benefit out of the medicine for our patients. So here we have a chart with some of the more common Parkinson's disease medicines that you might be seeing. So we'll start with carbidopa levodopa, which is brand named called Sinemet. So this is a decarboxylase inhibitor dopamine precursor. So our levodopa is what is our precursor for dopamine. That gets converted by decarboxylase into the dopamine. And then the carbidopa, what it's really doing is inhibiting decarboxylase enzyme from converting the levodopa to the dopamine, inhibiting that from happening in our peripheral areas as opposed to in our blood-brain barrier. So that way the levodopa can then move into the blood-brain barrier and get converted to dopamine, and thus increasing our dopamine levels there. And so some of the common adverse events that can occur with carbidopa levodopa include orthostatic hypotension, constipation, dizziness, hallucination, and some motor complications, which I'll talk about in the next slide. And something important to keep in mind, just because of the absorption of how this medicine can be absorbed in, is to make sure that patients take it on an empty stomach. We have also here then next is entacapone. So this is our catechol-O-methyltransferase inhibitor, or our COMT inhibitor. So this is a really important, this is a medicine that can also help reduce the peripheral conversion of levodopa to dopamine, so that way we can get it to our blood, to our brain faster. It's really important that this medicine can be given only with carbidopa levodopa. Because if you give it without it, then it's not really going to work because it's not adding anything. It's just kind of stopping the peripheral conversion of levodopa to the dopamine. So there is a formulation out there that you can give that's carbidopa, levodopa, and entacapone together. But you can also just go ahead and prescribe this as well by just itself, by its lonesome, really, the entacapone plus the carbidopa, levodopa, if you so choose. The other two drugs here listed are our MAO-B inhibitors. So they work by preventing degradation of dopamine in our presynaptic neuron and adjacent glial cells. And so selegiline is one of them. And some common adverse events include nausea, insomnia, hallucinations, weight loss, GI upset as well. And then the razagiline, which can also cause headache or hallucinations. And something to also keep in mind is that this will reduce the wearing off time by about 1 hour. So sometimes this can be a really good adjunctive treatment to if the patient is experiencing that wearing off symptoms, which I'll talk about in the next slide, with the carbidopa levodopa. So carbidopa levodopa can have some motor complications, and that's often called these on-off syndrome. So when we talk about on symptoms, this is really when levodopa is working how it's supposed to, and the patient is able to have the full effect of the medication. Sometimes if they have too much of the full effect or starting to have some more side effects, that's when we would want to consider maybe decreasing the dose of the carbidopa levodopa and seeing how the patient fares on that. For our off symptoms, what that kind of means is that the levodopa has now worn off. So with that being said, the patient can now start experiencing tremor, rigidity, and slow movements. And that can usually happen a lot in between doses. And then also just as Parkinson's disease also progresses as well. So some of the things that we can do to kind of help with those off symptoms are to increase the frequency of dosing that we give the carbidopa levodopa. So some things that I've seen in practice is patients might be taking the immediate release carbidopa levodopa like 3 or 4 times a day, sometimes 5 times a day, and kind of just seeing what the best dose is that helps relieve some of these symptoms, the Parkinson's disease symptoms for our patients. And those are some of the things that we can do with the carbidopa levodopa. Another thing that we can do to kind of help with these off symptoms are to add a COMT inhibitor. So that's when entacapone really comes into play here. And then another opportunity or area for medication optimization is to switch the carbidopa levodopa to the ER, extended release formulation, which is called Rytary. And that can also kind of help extend how long the levodopa is going to work. There's also another symptom called freezing. So that's when the patient is experiencing uncontrolled movements, or this time when they kind of just freeze and have this temporarily inability to move. So if that does happen to the patient, some of the things that we can do are to increase the dose here as well. And we don't really see this as much in the early disease, but we do see it when we start using early levodopa as well. And then there's also this delayed on symptom that patients can also kind of complain about, and that's really where they feel like they don't get the full effect, and it just takes a little bit of time for them to see the full effects of the levodopa. And so if that happens, some of the things that we can tell our patients to do are to try making sure that they take the levodopa without food on an empty stomach to kind of prevent that from happening. Our other medications that we can use for Parkinson's disease include our dopamine agonists. So these examples of these include pramipexole and ropinirole. So the way these drugs work are by directly stimulating our dopamine receptors, and thus they increase how much dopamine is released in our body and in our brains. Some common adverse events that can occur with these include GI upsets, being sedated, having hallucinations, and having some impulse control disorders. Some things to keep in mind with dopamine agonists is that they can be used either as monotherapy, especially if you think back to our algorithm earlier on, and if the patient is, for those patients who are less than 60 years old, this could be a really good option to use, especially because it'll help with that levodopa sparing effect, since we're not immediately using the levodopa and rather just increasing the dopamine by using our own innate dopamine with stimulating the dopamine receptors. That way we don't add on the levodopa early on, and then we can kind of prevent or delay the use of the levodopa, which then would prevent some of those motor complications that happen with the carbidopa levodopa. Our other medications that we use are some anticholinergics. So an example of this is benztropine or cogentin. So the way that this one works is by blocking the action of acetylcholine, and thus when we do that, we also block the reuptake of dopamine. So since it's an anticholinergic, some of the more common side effects include dry mouth, blurred vision, constipation, urinary retention, and hallucinations. And so we use these in our younger patients who don't have any cognitive impairment, but it's really good to help, but have that tremor, because it's really good at helping with the tremor symptoms from Parkinson's disease. Our other last drug is amantadine. So this is an agent that enhances the dopamine release in our bodies. Some common adverse events include confusion, orthostatic hypotension, sedation, and dry mouth. This is a really good add-on agent when the patient is complaining of that levodopa dyskinesia. And then something to just really watch out for is that it is renally adjusted because it is metabolized by our kidneys. So if a patient has some kidney dysfunction, then they would need to be renally adjusted with this medicine.
So to summarize, Parkinson's results from reduced dopamine in the brain. Medications are used when Parkinson's symptoms interfere with the quality of life and activities of daily living for the patients. And carbidopa-levodopa is often reserved for treatment of older or more advanced patients, since its effect does wear off with time that it's used. Lastly, we'll be talking about anti-epileptic drugs, or AED.
We're going to start with a quick overview of seizures and epilepsy. Seizures occur when excitatory neurons produce a sudden surge of electrical activity in the brain, which we'll discuss more when we talk about anti-epileptic medications and their mechanisms. Epilepsy is defined by at least 2 unprovoked seizures occurring more than 24 hours apart, or 1 unprovoked seizure and a high probability for further seizures to occur, or diagnosis of an epilepsy syndrome. And epilepsy has the highest incidence in pediatric and elderly patients, so really those extremes in age. In terms of presentation, symptoms can vary depending on the specific type of seizure. So we're going to talk briefly about each one. Generalized seizures affect both sides of the brain, and we can see absence seizures, which is really more like rapid blinking or the patient just blanking out and staring into space for a few seconds. We can also have tonic-clonic seizures or grand mal seizures, which can cause crying out, loss of consciousness, falling to the ground, and muscle jerks or spasms. Moving into focal seizures, these are located in just one area of the brain, so they're also called partial seizures. We can have simple focal seizures, which affect a small part of the brain and may cause some twitching or a change in sensation. Complex focal seizures can make a person confused or dazed, and the patient will likely be unable to respond to any questions or directions for up to a few minutes. And then secondary generalized seizures typically begin in one part of the brain and then spread to both parts of the brain. So it starts as a focal seizure, but is followed by a generalized seizure. Patients can also have seizures of unknown onset, so really unsure of whether it's generalized, focal, or if it falls into any of the categories listed above.
Anti-epileptic drugs have a few different main mechanisms of action. So they can act on GABA, which is the main inhibitory neurotransmitter. So with GABA stimulation, inhibitory effects on the brain are induced, and that reduces seizures. Decreased glutamate, since glutamate is the main excitatory neurotransmitter, kind of has the opposite effect of increasing GABA. Blocking calcium channels, which slows or stops the transmission of electrical signaling, again to reduce the frequency of seizures. And then blocking sodium channel, again, which would decrease the amount of neuron firing, again to sort of reduce the frequency of seizures. We have a few drug tables in this presentation for AEDs. There are a lot of them, and a lot of them do have pretty significant side effects that are presented kind of in the middle there under unique adverse effects. So kind of point out some important ones as we go along. Lamotrigine has serious skin reactions, so it's important to titrate this medication slowly and start low and go slow. It is one of the safer options to use in pregnant patients, so if you run into that issue, it could be an option. Keppra is kind of a mainstay of therapy as far as I've seen in my practice. It does have some adverse effects of psychiatric reaction, kind of called Keppra rage colloquially, but again, one of the safer options in pregnancies, and it doesn't have any significant drug-drug interactions, which makes it pretty attractive as an option for patients who have seizure disorders. Next agent is topiramate or Topamax. Big side effect with this one is somnolence, difficulty with memory and concentration. It also has some other off-label uses for migraine prophylaxis and weight loss. So if you have a patient with other comorbidities like migraines or obesity, this could be an option for them as well. And then valproic acid or Devalproex is something we've already talked about as a mood stabilizer, but like I said before, it could be used as an anticonvulsant as well. Some things to look out for, like I said before, hepatic impairment or liver dysfunction, as well as thrombocytopenia. It is teratogenic, so that's something to make sure your patients are aware of before starting it. It also has some other off-label uses, like bipolar disorder and migraine prophylaxis. It does have a lot of drug-drug interactions, so again, something to screen for before you're starting a patient on this one. Our next set of drugs include carbamazepine, which also has serious skin reactions, so starting low and going slow as we titrate these patients. It has some effects on the CBC with aplastic anemia and agranulocytosis, so something to get a baseline lab at least for these patients and kind of monitor throughout their therapy. It has a lot of drug-drug interactions, so again, something to screen before starting any patient on it. It is an autoinducer, so as patients builds up the drug level in their system, the drug actually metabolizes itself and brings down the serum levels kind of as therapy continues. So you may see patients, have a therapeutic level and then all of a sudden it drop off, and that is the autoinduction of carbamazepine metabolism. It is similar to oxcarbazepine, which is trileptal. It's a cousin, and it's also used in bipolar 1 and for the treatment of neuropathy. Lacosamide or Vimpat, it is a controlled substance, not used particularly commonly as far as my practice and for what I've seen, and it does have a risk of arrhythmias with its use. Phenobarbital is also a controlled substance, has a lot of drug-drug interactions, and can be habit-forming, so something to consider before starting patients on this med. And then phenytoin or dilantin can also be used as an AED, and it also has a lot of drug-drug interactions. The ability to monitor serum levels, which is nice for patients for monitoring toxicities and things like that. It is a teratogen, so again, something to consult patients on before starting. And then it does have some pretty unique adverse effects that are listed kind of at the bottom there, with gingival hyperplasia, hair growth, and hepatic toxicity, as well as some dose-related toxicities, again, relating to high serum levels. So therapeutic drug monitoring can be used for some of these medications, which I kind of previously mentioned throughout, but these are the main ones that we would think to monitor serum levels for these patients kind of as they proceed during treatment. So phenytoin, carbamazepine, valproic acid, and phenobarbital are all medications that we would want to monitor levels for these patients, and the goal levels are presented there, and kind of how to monitor the patients and when to get levels as well.
There are also some medications that can lower the seizure threshold, and so these should be used in care in patients who are already predisposed to seizures or may have epilepsy disorders. It can include varenicline, bupropion, penicillin, tramadol, clozapine, carbapenems, meperidine, and quinolones. Another consideration is that when patients are on anti-epileptic medications, if they're stopped abruptly, this can also result in a lower seizure threshold and can result in seizures as well.
Other considerations to take into account with patients with epilepsy, this can be a very complicated disorder, so the patient may need referral to a neurologist or even an epileptologist for their treatment. Particular considerations for women include the fact that most AEDs do interact with oral contraceptives that make them less effective. So it's important to make sure that women who are sexually active are counseled on this interaction and making sure that they're using backup contraception as well. Monotherapy with AEDs is preferred in pregnancy, so just one agent as opposed to multiple for control of seizures, and valproic acid is recommended to be avoided in the first trimester of pregnancy due to its teratogenicity. AEDs do increase the risk of suicidal behavior and suicidal ideation, so if you have a patient at risk for these events, then it's important to make sure that they are aware or making sure that their family members or caregivers are monitoring the patient for these types of reactions as well. Sexual dysfunction has also been reported by about half of patients on AEDs, so again, something to make sure your patients are aware of before starting treatment. And all states do have driving restrictions on patients with epilepsy diagnoses. So some states may even require reporting to the Department of Transportation by the medical provider on behalf of the patient's diagnosis. So just something to be aware of as you may or may not encounter these patients in your practice. So to summarize, AEDs have four main mechanisms of action involving sodium channels, calcium channels, blocking glutamate, and increasing GABA transmission. One AED can have multiple mechanisms, so you can kind of pick and choose from the list of four there. AEDs often have many drug interactions, so it's important to check for interactions before prescribing any new medications in a patient who takes AEDs. And some AEDs that I previously discussed require therapeutic drug monitoring to ensure efficacy without incurring toxicity or troublesome side effects.
That wraps up week 1 of CNS drugs. Please feel free to reach out if you guys have any questions, but otherwise we'll see you in class.